Thank you. My name's Dr. Jim Newton. I'm a consultant cardiologist at the John Radcliffe Hospital in Oxford, with a particular interest in echocardiography and in particular echocardiography for structural interventions. And I'm very grateful to the Heart Valve Society for the invitation to speak to you this evening. And I've been tasked with covering the imaging aspects of tricuspid valve disease. What are the objectives of my talk? Well, I'm hopefully going to remind you of normal tricuspid valve anatomy, because like any imaging procedure, you've got to understand normal anatomy in order to be able to assess it. I'm going to talk through the etiology of tricuspid valve disease, but exclusively tricuspid regurgitation, given that tricuspid stenosis is vanishingly rare and almost always due to rheumatic disease. I'll talk through some tips and tricks on how to use echo to evaluate tricuspid valve disease. And we'll think a little bit how best to describe pathology and how to report tricuspid valve disease and some of the key measurements. And we'll talk through the recently revised grading scheme for tricuspid regurgitation. And then we'll think a little bit at the end about the use of multimodality imaging, and in particular how you might integrate echo findings into other imaging modalities and put them all together to comprehensively assess tricuspid valve disease. I would point you towards three key references. This paper by Dr. Hahn, who certainly is leading the field in assessment of tricuspid regurgitation, and in particular for interventions, has written this very thorough article a few years ago now in Circ Cardiovascular Imaging. And a lot of the images and cartoons I'll be showing you are taken from this article. And I would encourage you to go and read this if you are likely to be involved with the assessment of patients with significant TR. There's been several really very thorough and again very useful reviews about where 3D echo might fit in the imaging and assessment of tricuspid valve disease. And this is again a recent one from last year that again is very thorough and has some very useful step-by-step guides that certainly I found very helpful. And then lastly, of course, is our European Association's guideline on assessment of valvular disease by echocardiography. And this is particularly useful to go through and understand the quantification assessments, but I will touch on these. Why have I chosen to focus on tricuspid regurgitation? Well, again, partly because TS is so rare, but also because tricuspid regurgitation is really very common. And as we all know, we see tricuspid regurgitation to a mild degree in an awful lot of patients, particularly with modern echo equipment. And it's also clear that if you have moderate or severe tricuspid regurgitation, your outlook is not good, and in fact probably worse than we previously thought or considered. And there are a lot of patients out there, of course, who maybe had mitral interventions, principally surgical, in the previous decade, where the tricuspid disease was left in the hope that it would resolve or recover. But actually, if you leave these patients with moderate or severe tricuspid regurgitation, their short, medium and long-term outlook is significantly worse compared to mild TR. And we know that severe TR can cause a lot of symptoms, a lot of morbidity, and as you can see here, mortality. So we are likely to be seeing a lot of these patients come back to us with symptomatic severe tricuspid regurgitation, and there's of course a whole raft of interventions and procedures being devised and developed, which we'll hear about later on. And our job when we image these patients is to determine the cause of the tricuspid regurgitation, perhaps give some clue as to whether it could be treated. And to do that, we need to understand really how a normal tricuspid valve works and then understand the pathology. I'll just pause now and just remind you of some normal figures for tricuspid valve function. Remember, it's the largest valve of the heart. And it's the largest valve of the heart because blood flow is slow between the right atrium and the right ventricle and at low pressure. So in order to accommodate a normal stroke volume, the valve has to open to a wider degree than even the mitral valve. Therefore, velocities across the tricuspid valve are usually very low, typically less than 1 meter per second. And if you see a tricuspid E wave of more than 1 meter per second, then you should think, could this be stenotic? Probably not. Could, however, there be important tricuspid regurgitation and an increased stroke volume across that valve? And the same goes for the mean gradient. And I think it's true to say we probably don't routinely measure the tricuspid E wave or the inflow gradients, but perhaps we should start doing that routinely. And of course, one of the challenges with the tricuspid valve is it's the valve with the most variation in what we might consider to be normal anatomy, certainly when compared to the mitral or aortic valves. And a lot of the way we approach the tricuspid valve is analogous, and in fact, largely lifted from how we look at the mitral valve, in that, of course, it's not just the three leaflets. We should consider the tricuspid valve as a complex that includes the annulus, which, again, like all the other valves, is not a discrete, rigid, planar structure. It's really quite complex. The leaflets themselves, the papillary muscles, which attach the leaflets to the ventricle via the chordae. And this graphic here just reminds you of the important structures immediately adjacent to the tricuspid valve, notably the bundle of His in the AV node, the right coronary artery, which, as you can see, runs extremely close to the base of the anterior leaflet, and then the aortic valve just next door. It is important embryologically to emphasize, however, that the tricuspid valve shares no continuous fibrous body with the aortic valve, unlike the mitral valve. They are separate tissue origins and separate structures. Moving on to the tricuspid annulus, you won't be surprised to hear that it's larger than the mitral annulus, but it is a similar shape in that it is not planar. It's elliptical when you look at it from above, and it's saddle-shaped if you imagine looking at it from the side. The high points sit at the base of the anterior leaflets and at the septal posterior commissure, the low points, and the high points sit at the anteroseptal commissure near the aortic valve and the middle of the posterior valve on the lateral side. It's difficult to appreciate on echo, but the annulus contracts considerably during diastole and systole, and that contributes to competence of the tricuspid valve. And as we'll see a bit later on, patients who lose that contraction, sometimes that's part of the reason they develop tricuspid regurgitation. A figure to have when you're scanning somebody and reporting the echo is that the annulus dimension should be of the order of 25 to 30 millimeters if you measure from the base of the leaflets in the four-chamber view. And if you measure a maximum diameter of the tricuspid annulus of more than 35 millimeters, then that's abnormal, and the index value, if you choose to use that, is there for your reference. Just thinking about the three leaflets of the tricuspid valve, the anterior leaflet is usually the largest. It extends from the right ventricular infundibula, just anterior to the aortic valve, round and across to the infralateral wall. It's the largest leaflet, but it can often be notched, and sometimes it can appear to have a cleft, and there have been reports of pairs of anterior leaflets in some patients. The septal leaflet obviously attaches principally to the interventricular septum, but also runs around to the posterior wall of the left ventricle. And remember that in your four-chamber view, the septal insertion should be more apical than that of the anterior mitral valve leaflets. And if that doesn't appear to be the case, then you may be scanning somebody with some atrioventricular septal defect, or perhaps a patient who's had a repaired AVSD. The posterior leaflet sits around the posterior margin of the tricuspid annulus and wraps around to the infralateral wall where it meets the anterior leaflet. There are then the papillary muscles, and I suppose the most important point here to make is these can be very variable, and there aren't many hard and fast rules, other than perhaps to say the anterior papillary muscle usually is the largest and most prominent, and it's typically attached to the moderator band as it travels down into the right ventricle, as shown here in this anatomical sketch. The septal papillary muscle is often the smallest. It can be completely absent in some patients, or it can just be chordae inserting directly into the septum without a discrete papillary muscle. The posterior papillary muscle, again, is usually small. It can be bifid, and there's quite a wide variation in the posterior papillary muscles. And again, in some patients have been reported to have anything up to 7 or 8 discrete papillary muscle bundles. So the one you're likely to see on an echo is the anterior one. And if you can see it inserting into the moderator back, that's a good way to define it. The chordal attachments, again, are highly variable, and most papillary muscles will provide chordae to at least 2, if not all 3 of the leaflets of the tricuspid valve. So if you encounter a patient who has tricuspid regurgitation, again, in a manner analogous to how we subdivide mitral regurgitation, I think it's useful to think about whether you're looking at primary tricuspid regurgitation, which you can think of as a problem with the anatomy of the tricuspid valve itself, any part of the tricuspid valve complex, or some restriction or aberration of leaflet motion. Or are you looking at a patient with secondary tricuspid regurgitation, where in fact the leaflet anatomy themselves are normal, and it's some other problem leading to valve dysfunction? And then there's also this curious, perhaps recently described entity of idiopathic tricuspid regurgitation, where there's nothing apparently wrong with the leaflet anatomy, and there is nothing wrong on assessment of the right ventricle, but the patient has tricuspid regurgitation. And I will come on to that group a bit later on. Thinking of primary tricuspid regurgitation, I'm just going to show you a few quick examples. Clearly, it can be congenital, the commonest of which would be Epstein anomaly of the tricuspid valve, where the anterior leaflet is displaced into the right ventricle. I'm not going to cover that, that's really a whole separate talk, and wouldn't really fall into the remit of treatments that we're perhaps discussing later today. Acquired causes, there's a list here, you can add others to this, but I'll show you a few examples just now. So I'm going to show you these echo loops in detail for each case, but just 2 echo loops just to emphasize the pathology. Carcinoid is not that common, but it is, I hope, easy to define on echo because it gives this curious and almost unique appearance of completely rigid and fixed tricuspid valve leaflets. These leaflets are thickened, immobile, and neither open nor close, and the patient typically has very severe, if not free, tricuspid regurgitation, as shown in this right ventricular inflow view here. We occasionally see patients who are unfortunate enough to suffer actually injury to the tricuspid valve. Here's a patient who underwent an ablation in the right ventricle, and unfortunately the ablation catheter got entangled in the chordae, and on removal led to rupture of the chordae and really a flail septal leaflet here in this aortic valve short axis view, leading again to severe tricuspid regurgitation. Endocarditis of the tricuspid valve is, I'm sure, something we're all familiar with. The hallmark here is a vegetation, a mobile mass attached to the atrial side of the tricuspid valve leaflet, with probably a perforation adjacent to it, and severe tricuspid regurgitation. This is an increasing problem for all of us in that we know a lot of pacing electrodes that traverse the tricuspid valve can impinge on the leaflets and cause entrapment. They can perforate the leaflets, they can entangle in the chordae, or they could disrupt the perimuscles. And here's a patient with tricuspid regurgitation. This is often difficult to see clearly on echo, and you have to work hard to obtain a clear view, but I hope this transgastric long axis TOE image here on the left can persuade you that this right ventricular electrode of a dual chamber pacing system is impinging the anterior leaflet's return and stopping coaptation with the posterior leaflet and leading to, as you can see, significant tricuspid regurgitation. Now, of course, it's important to understand this because how you might hope to improve this valve function and the options available in terms of any intervention would be critically determined by the relationship of the pacing wire to the leaflets themselves. Just like the mitral valve, the tricuspid valve can degenerate, the leaflets can become thickened, they can prolapse or they can billow, and you can rupture chordae. And here's a patient with degenerate tricuspid valve disease, again on a TOE, showing that part of the anterior leaflet here is prolapsing, and I can perhaps persuade you there's a visible ruptured chordae. The pathology is very similar to that affecting the mitral valve, and in truth, the need for surgical repair again is followed in the principle similar to the mitral valve, with perhaps reimplantation of chordae and an angioplasty ring, but I'm sure we'll hear more about that from our surgical colleagues shortly. But perhaps where I want to focus our attention next is on the concept of secondary tricuspid regurgitation, where there's no intrinsic problem with the leaflets themselves, but dilatation of the annulus, dilatation of the right ventricle, progressive enlargement of the support structures of the tricuspid valve, pull the leaflets apart, and then tether the leaflets down towards the RV apex, preventing coaptation and causing regurgitation. And of course, tricuspid regurgitation begets atrial dilatation and right ventricular remodeling, which tends to exacerbate the tricuspid regurgitation further. And here's an example of that. So here's a right ventricular inflow view on transthoracic echo. We have a clearly dilated adversely remodeled, very impaired right ventricle, tension on the papillary muscles, attentive tricuspid valve, and clear, severe, if slightly eccentric tricuspid regurgitation. Just 2 slides now on idiopathic tricuspid regurgitation. This is often seen in more elderly patients, and to diagnose this, we have to be confident there's no left-sided disease or pulmonary hypertension. There's almost always atrial fibrillation, and that seems to lead to exclusively right atrial dilatation and then subsequent annular dilatation, but without the adverse remodeling of the right ventricle. And that can cause, in some patients, really very severe isolated tricuspid regurgitation. And here's an interesting example. So here's a patient where on TOE, we can clearly see a huge coaptation defect between the tricuspid leaflets, massive annular dilatation, a degree of right ventricular impairment, if not impressive dilatation, and some tethering here, and clear severe tricuspid regurgitation on vena contracta measurement. This was during the patient's time in atrial fibrillation. They had a successful ablation, and within 6 months, their right heart, their right atrium, and their tricuspid valve function had returned entirely to normal with complete resolution of the tricuspid regurgitation. So we do see these patients. I wouldn't say they are common, but if you can find no other pathology on the scan apart from a dilated right atrium and severe TR, it's worth questioning whether this is AF related. So how do we assess the tricuspid valve with echo, which is the predominant imaging modality? Well, the first thing to say is that we have to integrate transthoracic and transesophageal. We can't just rely on one. And because of the orientation of the tricuspid plane in the heart, it's very difficult actually to image all 3 leaflets in a single plane on any one study, although 3D perhaps does help us. If you go and read any textbook on the tricuspid valve or look up any paper, you will find quite easily discordance and disagreement on which leaflets are visible in which view. And the reason for that, I think, in part is due to the variation in tricuspid valve anatomy, and also the fact that it's quite easy to take slightly non-standard imaging planes and see different leaflets of the valve, as I'll demonstrate to you shortly. But I think to understand the tricuspid valve, you've got to look at these 3 views: the right ventricular inflow view, the parasternal short axis, and the 4-chamber view, and that could be apical or subcostal. If you think about the RV inflow view and look at the anatomy diagram on the right, your conventional parasternal y-axis view, which goes through the aortic valve and the mitral valve, we're all familiar with. If you angle the probe and swing across just into the right heart, and the first leaflet you will encounter will be the septal leaflet. And as we can see down here, if you have an RV inflow view with the coronary sinus in the image, you are highly likely to be looking at the septal and the anterior leaflets. But if you continue your sweep past the coronary sinus and into the right atrium itself, you'll then bring the anterior and posterior leaflets into view. So in fact, in that single view, you can sweep through all 3 leaflets. So if you're trying to identify an area of prolapse or perforation, for example, just sweep through the valve and think about your imaging plane in relation to other structures. The same is true of the short axis view. A conventional short axis view, as it in the sort of pale orange triangle, will include the aortic valve and will take your imaging plane through the anterior leaflets and sometimes also give you the posterior leaflets. To bring the septal leaflet in, you've got to lower the imaging plane, come under the aortic valve, bring the left ventricular outflow tracts into view, and then you'll pick up the septal leaflet as well as the anterior leaflet. From the 4-chamber, again, depending on exactly what level you're scanning through the heart, conventional 4-chamber being the middle line, you can elevate the plane to bring more of the anterior leaflet in, or you can depress the plane to bring more of the posterior leaflet in. So again, there's no fixed view, and to see all 3 leaflets, you've got to take a sequence of views and understand the relationship in a sort of anterior-posterior direction to your imaging plane to know exactly what leaflets you're looking at. TOE of the tricuspid valve is the next step if you're evaluating a patient in detail. It's more difficult than for the mitral valve, and the simple reason for that is that the esophagus does not traverse behind the right atrium in the same way it does the left atrium. And if you take a conventional mid-esophageal view, which gives you beautiful orientation for the mitral valve, left ventricular outflow tract, you can see here that the tricuspid valve is frequently out of plane. The solution actually is just to gently advance the probe a little bit further, and typically at this point, as we come round near the base of the left atrium, because the heart is rotated slightly in the chest, we then favour the right atrium, and we have a much clearer window onto the tricuspid valve. What you then need to do in some patients to bring the tricuspid valve clearly into view is anti-flex the probe. So lift the probe off the esophagus slightly, clearly not too far, otherwise you'll lose contact. But that often will give you a very, very nice, clear, unobstructed view down on the tricuspid valve. I would then proceed and take some transgastric views, and the short axis view I find very helpful. It does give you an on-fast view of the tricuspid valve and allow you to clearly identify septal, anterior, and posterior leaflets and a clear view of the right ventricle. And that's typically somewhere between 40 and 60 degrees in a relatively high transgastric position. If you have 90 degrees to your imaging plane, you get a long axis view where you'll conventionally see the anterior leaflet and typically the posterior leaflet in this view. And this is a very good view for looking at pacing wires coming into the RV, as I showed you earlier. The thing to remember actually is from a TOE viewpoint, you tend to always see the anterior leaflet. If you want to specifically image the septal leaflet, it's probably preferable to use a mid-esophageal view because you can see the septum itself. And clearly, if you can see the leaflet inserting into the ventricular septum, then we know it's the septal leaflet. To get the posterior leaflet separated, I preferentially use transgastric imaging, typically the short axis, and then a long axis to show me the posterior leaflet clearly. Does 3D help? The answer is yes, although it's not easy. You have to use a modified apical view where you favor the right ventricle. The key to good 3D is good 2D, so optimize your 2D first. Try and take a multi-beat acquisition, but many of these patients are in atrial fibrillation, so you may have to resort to 3D zoom. And you can do the same with TOE. Remember, the reason TOE for the tricuspid valve is difficult is that it's very rare for the tricuspid valve to be completely opposite the imaging plane like the mitral valve is, with good reflectivity from the leaflets. And for that reason, the distal esophageal window is good for systole because the leaflets are relatively on-fast when they're closed. And a transgastric window is good for diastole because the leaflets again are on-fast to the imaging plane when they're open. So you may need to take two separate views and integrate your 3D both in systole and diastole to fully understand leaflet motion. Plenty of groups are looking at advanced 3D analysis of the tricuspid valve, again using software borrowed from mitral analysis. And some groups have been printing out 3D annulus of leaflets. And I'm sure this could be of great value for developing and perfecting future intervention techniques. So how do we grade severity? How do we judge when a patient has tricuspid regurgitation bad enough to warrant some form of treatment? Again, like every other valve assessment, the overriding message is resist the urge to grade simply on the appearance of colored Doppler. It often underestimates, particularly with eccentric jets, particularly with multiple jets, particularly with wall-hugging jets. And we should, where possible, quantify, but we have to accept that all these techniques have limited validity because there's no true proven gold standard for quantifying tricuspid regurgitation. And whenever we generate a quantifiable parameter, make sure it adds up and is concordant with other simple measures that I'll show you shortly. If you're going to measure something, measure the vena contractor, use the inflow view or the four-chamber view, work hard to get the tricuspid regurgitation jet as wide as you can, and measure the narrowest point as the TR traverses the valve. If you measure a value greater than 7 millimeters, it's severe tricuspid regurgitation. Theoretically, PISA works just as well as for TR as it does for mitral regurgitation. The usual caveats apply that for multiple jets it's difficult, for eccentric jets it's difficult, and of course it's very rare the tricuspid orifice is perfectly circular, but the technique's exactly the same. Align with the jet, shift the color baseline down in the direction of the jet, so don't adjust the scale, adjust the baseline, and try and develop a clear transition zone at a predefined velocity that allows you to measure the radius of that hemisphere down to the vena contractor. Then use a continuous wave and measure the VTI and maximum velocity, and from that you can derive your orifice area and your regurgitant volume. A single measurement of jet area is another recognized technique, but it's highly dependent on the image you choose, and it's critically dependent on the Nyquist limit, as demonstrated down here, where for the same patient at high Nyquist limit we have mild by color. On the right here we have what you might call more moderate or perhaps severe. So again, be cautious using this technique in isolation. It's easy to get it wrong. The vena contractor, I tend to favor measuring from the four-chamber view, and again, 7 millimeters is the cutoff. If you measure or derive a regurgitant orifice area greater than 40, that's typically severe. As a rough rule of thumb, if your piezo radius around a Nyquist limit of 30 is greater than 0.9, you're likely to be looking at severe TR. We then need to sort of look at the consequences of the TR, and the most useful thing to do next is look at hepatic vein flow reversal. Imaging hepatic veins is usually quite straightforward. We're all familiar with looking at the IVC. A slight modification of the transducer position will often bring a hepatic vein into view. A pulse wave well into the vein, looking for systolic flow reversal, is what you need to evaluate. If you find it, there probably is severe TR. Remember, some patients with severe TR may not have this if there are confounding factors as listed here. And remember to critically evaluate the continuous wave Doppler envelope. The density, again, reflects the stroke volume of that regurgitative lesion, and the shape is a good clue. And we all know that with severe TR, you typically get this early peaking triangular shaped jet compared to a more rounded symmetrical jet in less severe TR. And just make sure it all fits. So again, go back and look at your tricuspid E wave. In severe TR, you'd expect the E wave to be abnormally high, getting closer to 1 meter per second. And make sure your tricuspid regurgitant velocity, again, seems to fit with what you're assessing in terms of severity. But of course, the catch is when you get very, very severe TR, you have very little gradient between the RV and the RA, then your velocity measured here is not a true reflection of your pulmonary artery pressure. Here's the conventional severity grading, and these are the sort of numbers you might want to work to for your quantifiable measures and your objective assessments. But more recently, there has been a push to, rather uniquely for the tricuspid valve, added 2 additional gradings at the top. So you can now be graded as having severe TR, massive TR, or torrential TR. And if you want to read the justification for that approach, the reference is down the bottom for you. But it's the recognition that you can have really very, very severe or torrential tricuspid regurgitation and have an intervention that reduces your stroke volume enormously, but you probably might be left with severe TR. But in fact, you have had a 2-grade reduction and will likely get a huge symptomatic improvement. So I do see the rationale for extending the grading. And we know that patients with massive TR have a lot to gain if you reduce their stroke volume even by 30 to 40%. You have, of course, got to look at the right ventricle in detail. And I'm not going to cover that today because that's a whole nother talk. But measuring right ventricular size, measuring right ventricular function, assessing the pulmonary valve, etc., is all a critical part of evaluating the tricuspid valve. So when you report an echo, be precise on the etiology, clarify the affected leaflets, of course, report right ventricular chamber size and function, ensure this is not a consequence of untreated left-sided disease, grade your TR, don't just use color, quantify, and you should measure and report the tricuspid annulus in 2 planes. I tend to report the 4-chamber plane and the RV inflow plane, or you can use 3D. Further measurements really are going to be dictated by the treatment you may be involved in assessing the patient for, and the new devices and therapies that are being developed will have their own unique set of measurements you may be required to take, and you've got to liaise closely with your research and interventional colleagues to provide a data set that works for them. I'm just going to finish with a couple more slides now on other modalities. MRI, again, just like any other valve lesion, can precisely quantify regurgitation by allowing you to measure stroke volume in 2 separate areas. So it can give you a very precise assessment of the volume of flow and therefore the severity of tricuspid regurgitation. It's of course the gold standard for quantifying right ventricular size and function, but it is a very limited value for evaluating tricuspid leaflet anatomy or predicting the requirement or criteria for any form of intervention. CT, of course, is emerging as a utility for any structural intervention, and you get beautiful images of the tricuspid valve, and you can precisely measure the annulus, although you have to kind of force it to conform to a flat plane. But you can get very precise diameter measurements in 2 planes, circumference measurements in areas, and of course it allows you to precisely evaluate the adjacent structures, notably the right coronary artery. The real sort of challenge for both those doing the imaging and in fact in particular for those doing the intervention is trying to put all the separate modalities together and understanding the relationships between the appearances on TOE here, 3D TOE here, CT evaluation of the tricuspid leaflets and annulus here, and then live fluoroscopy in the cath lab and the relationships between the right coronary artery and the tricuspid leaflets, which of course can't be seen, is in truth an enormous challenge and takes lots of practice and takes very close collaboration and agreement between the person providing the live imaging and the interventionist to make sure you're speaking the same language, you're talking about the same structures, and you're orientating your views in an organized and collaborative way. Technology might help us all. We've probably all seen the sort of navigator solutions where you can overlay the echo images to the fluoro, and these can be of really quite significant benefit when you're trying to treat these tricuspid valve problems. And it won't perhaps be too long until we're all donning VR headsets and looking at floating holograms of our valve anatomy live in front of us rather than over the tricuspid fluoroscopy. So I'm going to finish there, and I hope I've reminded you of the normal anatomy of the tricuspid valve. I hope I've given you some tips on how to evaluate it. I'd encourage you to think about the etiology very carefully, and when you report the tricuspid valve anatomy, talk about the leaflets, the annulus, the papillary muscles. I think we should quantify and we should use the tools carefully, but again, as with any echo report, make sure that all your measurements are in agreement and concordance, or if they're not, talk about why that might be. And of course, the key step is to work extremely closely with your surgical intervention colleagues to make sure that you're providing a data set that's useful to them, gives them the information they require to plan and to potentially assist and guide any following procedures. I'm going to finish there and thank you for your attention. My email address is there if you've got any questions or you want any images or slides from this talk, just drop me an email and I'll gladly share those with you. And I look forward to any questions later on. Thank you very much.